Hello and welcome to Complex Regional Pain Syndrome Lecture number 2. In this lecture, we'll be talking about different therapeutic options to manage CRPS. So let's do a review of our treatment. So what drugs are typically used for the treatment of CRPS? These are all of the pharmacological agents that should be intuitive to you by now. So basically, these are going to be non-steroidal anti-inflammatory drugs, and these are going to be used for moderate pain. You can use things over the counter such as ibuprofen, naproxen, Aleve. Corticosteroids, just like in osteoarthritis or rheumatoid arthritis, when we use them to relieve inflammation and swelling, these are going to be used to relieve inflammation, swelling, and also edema as well. And these are going to be drugs such as prednisolone or methylprednisolone, used primarily in the early stages of CRPS. Also, drugs that were initially developed to treat seizures, such as anticonvulsants, and depression, such as antidepressants. But now they have been shown to be effective in neuropathic pain disorders, and we're well familiar with these drugs. These are gabapentin, pregabalin, known under the brand name of Lyrica, amitriptyline, nortriptyline, and then duloxetine. Also, Botox injections, opioids such as OxyContin, remember this is a brand name for oxycodone, morphine, hydrocodone, fentanyl, and Vicodin. And you should remember what two drugs are components of Vicodin. Also, NMDA receptor antagonists such as dextromethorphan and ketamine. Nasal calcitonin specifically for deep bone pain. And lastly, topical anesthetic creams and patches such as lidocaine creams. All of these drugs in combinations can have various side effects such as drowsiness, dizziness, also increased heart rates, some form of memory impairment. So if you're taking any of these drugs or a combination of these drugs, you should be aware of the side effects so that you can report it to your healthcare provider once you start your therapy. So here's a picture we previously looked before in a pain management picture, and this picture was illustrating multimodal approach to therapy that we can use, basically utilizing different pharmacological agents to target the pain transmission pathway along several junctions of that pathway. For example, here it says NSAIDs. So remember what NSAIDs do. They're going to inhibit the actions of enzymes COX-1 and COX-2, and they're going to inhibit production of inflammatory cytokines. So the inflammatory cytokines can actually work or act on the peripheral nociceptor endings, and those can get sensitized and start producing firing or electrical potentials that will be sent up all the way to the brain. So utilizing a combination of different drugs, we can try to stop the pain signal transmission along several junctions, and that's why we're going to use several drugs, and I'm going to talk to you more about it. So here's a great picture from an article that basically described a case report of a patient who sustained trauma to her spinal cord and developed CRPS in her right dominant hand. Remember that sort of CRPS would be classified as CRPS 2 when you actually have an identified nerve injury. In her case, it was trauma to the spinal cord. So this is what the patient looked like when she initially presented for treatment. You can see that for successful therapy and in order for the therapy to be optimal, remember you have to utilize several different approaches. So you can't just blast somebody with drugs. You need a wholesome approach. You need physical therapy, rehabilitation, and occupational therapy. So in her case, she needed physical therapy, in order to help her with her hand. This was her dominant hand. Fortunately, she had such severe hyperalgesia and allodynia in her hand that it was hard for her to do the physical therapy because she experienced so much pain. So what the researchers did is they utilized lidocaine cream, and I believe it was lidocaine 5%, to help her with the physical therapy. And you can see this is her progress at 2 weeks, and now look at what an amazing result you see 2 months later after initiation of treatment with topical lidocaine. Look at the hand here and look at the hand here. So this is 2 months of doing physical therapy and also treatment with lidocaine. So one drug we haven't really talked about before in all the other lectures is basically Lyrica. Lyrica is a brand name and the generic name is pregabalin. Now pregabalin should sound familiar to you. It sounds something like gabapentin. There's GABA in the name here, and that's about right, because what Lyrica actually is, it's anti-epileptic drug. This is its chemical structure, and you can see that it's both related to gabapentin and it's also structurally related to a neurotransmitter GABA. And if you remember GABA, it's actually a neurotransmitter that is basically, it's an inhibitory neurotransmitter that plays quintessential roles in our physiology. So pregabalin was initially approved in US and Europe as an adjunctive therapy for treatment of seizures, but it has since been approved for treatment of various pain disorders, specifically neuropathic pain, such as post-herpetic neuralgia, diabetic neuropathy, spinal cord injury, nerve pain. So now it's a very effective drug used for the treatment of pain. And how does it actually work? So remember, oh, and by the way, here's a slide that illustrates, we talked about this before, that anticonvulsants are very effective, and randomized control trials actually demonstrate their efficacy in different neuropathic pain disorders such as trigeminal neuralgia, diabetic peripheral neuropathy, post-herpetic neuralgia, HIV polyneuropathy, spinal cord injury. So it's not surprised that Lyrica is actually approved for all of those conditions. So how does Lyrica actually work? What is its mechanism of action? So it's similar to gabapentin, remember, so it's structurally similar to gabapentin. So the hint would be that it sort of works somewhat similar to gabapentin. And remember, how does gabapentin actually work? So gabapentin is going to bind to the voltage-dependent calcium channels, and it's going to reduce the influx of calcium into the cells. And basically, it's likely going to influence neuronal functions through binding to the calcium channels. And that's what basically Lyrica also does. So it's going to bind to the alpha-delta subunits on the voltage-gated calcium channels, and it's going to reduce abnormal neuronal excitability. And one more thing I wanted to mention about Lyrica is that even though it's very structurally similar to GABA, so you can see the structural similarity, it doesn't actually bind directly to GABA receptors. It doesn't augment the actions of inhibitory neurotransmitter GABA, and it doesn't actually have any effects on the degradation or uptake of GABA. So now that we're familiar with all of these drugs that are used for the treatment of CRPS, let's put them together and let's see what clinical picture we come up with. So we have non-steroidal anti-inflammatory drugs. We have local anesthetics here, such as lidocaine. We have NMDA receptor antagonists, such as dextromethorphan and ketamine. We have anticonvulsants, such as gabapentin, and antidepressants, such as amitriptyline. So when we put them all together, what do we get? Ta-da! We get a compound. So this is a topical compound that could be used for pain, and this is compound P216. What do you see here? You see that there's an anti-inflammatory, so an NSAID here, and this specific NSAID is ketoprofen dosed at 10%. So here you have the non-steroidal anti-inflammatory. Then you have gabapentin, which is going to be an anticonvulsant to treat seizure and neuropathic pain. Then you're going to have a topical anesthetic, and all of these drugs are in here. So this is compound P216 that's designed to treat neuropathic or amputation pain, but it could be easily used for CRPS. So here's compound P213. Let's look at all the drugs in this compound. So here you see that there's ketamine. And ketamine is going to be an NMDA receptor antagonist that we're going to use to treat CRPS. You also see that there's an amitriptyline. Remember, this is an antidepressant. And then lastly, the two things I want you to pay attention to is ketoprofen and ibuprofen. What are these for? These are going to be your non-steroidal anti-inflammatory that you need to treat pain and inflammation. Well, so now you're looking at this compound and you're asking yourself, why do I have ketoprofen in here and why do I have ibuprofen in here? Both are non-steroidal anti-inflammatories, so why would I need two? And a common misconception is that ibuprofen is here for chemical reaction. It's not. If you had chemical reactions that are happening here, your compound would be unstable. You couldn't dispense it to a patient. So what is ibuprofen here for? Well, if you're familiar, if you have any background in medicine or pharmaceutical knowledge, I'll be happy to give you a brief overview. If you don't, it's fine. But let's just imagine somebody has a blood clot. And if they've had a blood clot, let's say in their artery, or they had a blood clot somewhere in their body, it's likely that they have some sort of pathology and they're likely to form another clot. So what we would do is we would put them on a blood thinning medication, such as warfarin, so that their blood is thin per se, and that they're not as likely, or they're not likely to form another clot. Well, warfarin is a medication that takes about 5 days to work. So what's going to happen for those 5 days? What if they form a blood clot that travels to their lungs or travels to their brain and then they die? We can't have that happen. So for 5 days, we have to treat them with something that's much faster acting that will do the same thing as warfarin does. So what we do is we actually bridge. It's known as a bridge protocol, bridging. We will bridge them to warfarin until it kicks in. So we will give them warfarin, but then we also give them another drug called low molecular weight heparin or dalteparin. And then basically, while they're waiting for the warfarin to kick in, they'll be using another medication, dalteparin, that will work to thin their blood until they reach therapeutic INR. So that's kind of like basically what we're doing here with ibuprofen and ketoprofen. So ibuprofen is it's a much faster onset of action versus ketoprofen. Ketoprofen takes a little bit of time to kick in. So until the ketoprofen kicks in, ibuprofen is what's going to provide some of that pain relief to relieve some of the inflammatory pain. So looking forward, what else do we have? So we have these compounds. So we have P214 for neuropathic pain. And again, remember, you have an NMDA receptor antagonist here. You have a amitriptyline here, which is for neuropathic pain, and you have an anti-inflammatory ketoprofen. Now, you see a lot of those compounds have a muscle relaxant in them. Oftentimes, if the joints are in so much pain, if the leg is in so much pain, perhaps the patient has some muscle aches, so the muscle relaxants can be beneficial. But if you're strictly treating neuropathic pain, then you don't really need a muscle relaxant in there. And then lastly, let's look at this compound. So we have compound, this is for allodynia, and remember, allodynia is a hallmark sign of CRPS. And what do we have in here? We have ketamine and we have an anesthetic. Remember, in CRPS, allodynia is very prevalent. It's a hallmark symptom. And this compound is actually great because this is a spray that you can spray on. The problem with creams is that if you have skin that's this distended and you have so much swelling and edema, when you're rubbing on a cream and you're rubbing it in really well so that it absorbs, that application of the medication can be very painful. So having a spray in there is wonderful because you don't provoke unnecessary sensation of pain via application of the cream. And there's a couple other compounds. This one's for plantar fasciitis, but it can be used for CRPS as well because it's just anti-inflammatory, ketamine, and the topical anesthetic. So, and then other compounds that you could use would be this one or this one, anything with anti-inflammatory. So basically the idea that I'm trying to convey is that you can really use any one of those drugs.